Thank you for doing this, by the way.
You bet.
So you gave your presidential address last night, which was excellent.
Thank you.
How do you feel after giving the address last night?
Not too many people fell asleep, which is always a good sign. It was a lot of fun. The presidents of the American Ulcer Society over the years have given different types of talks, and I kind of decided I would do a historical talk and then maybe end with some pieces of advice, probably mostly for the younger members, the younger folks in the audience, since there are several who know a lot more than I do. But so basically I chose a relationship between William Gowers, who was a London neurologist, and William Osler. And I kind of focused on their friendship. I thought it was kind of a fun way to learn about both of them and then how they interacted with each other. And I think they had a nice story. First, I learned from my main mentor in history of medicine research that history teaches humility. Osler, like all physicians, misdiagnosed people. He made mistakes with diagnosis and treatment from time to time. And, Gowers had a neurologic illness, and I kind of tried to show where probably what Osler thought that his friend William Gowers had as far as a neurologic disease was probably incorrect. But at the same time, Osler showed great caring and visited his friend when Gowers was on his deathbed. And there's some touching sort of primary source materials in the Osler library. So, putting that together, and then I kind of got obsessed with William Gowers over the years. I did 1 year of training in London, England, at this hospital called the National Hospital for Neurology and Neurosurgery, which is at Queen Square. And Gowers was basically the first resident or registrar there. So over the years, I kind of just became healthfully obsessed with William Gowers, easy for me to say. And I just kind of collected more and more material that kind of fed into that. So,
can you reflect a little bit now on what it means to have served as president of the society over the past year?
It's a huge honor. It's a 1 year term, and so you want to do something. The nice thing is there's sort of a run-in. You become second vice president, then first vice president, then you're president and such. But it's a huge honor, and I think, I guess what the main thing I tried to do is sort of increase awareness of the society and to remove barriers to membership. I think for many years, and I understand why, the American Ulcer Society had kind of a national honor society approach. Hard to get into. You need to have published history of medicine papers or attended so many meetings and such. And I think that's great. And there are many members who are very strong humanists and strong history of medicine researchers and know tons about history of medicine and William Osler as well. But I think over time, we needed to kind of change sort of the membership criteria to let someone who says, I'm interested, here's an example of why I'm interested. Can I be a member and see if it's a fit? So we kind of took the old category of membership and we kind of divided it from active membership, which is basically you're interested and you send us a little note and pay the dues and you're in, versus fellow membership, which is someone who's presented a paper at the meeting or attended a couple meetings and then becomes a fellow. So the old members all became fellows because they were already in, and we started this new category, which if one of the former presidents, Mike Jones, encouraged me when I was head of the membership committee to really think of ways to increase membership. And that was a fun working group. It was sort of after the first few months of the pandemic, and we met via Zoom and had a great group. And a lot of those suggestions, one of those was this change in membership to make it more open. The only reason to be the president of any society is to serve your members and to try to make some changes that you hope will make the society better. So that's kind of what I've worked on.
You write four messages from the president, right, in the Oslerian, and you chose to focus on teachers. Can you speak a little bit to why teachers and mentors are so central to who you are?
That's a great question. So I chose that partly because of my role. I work at the Mayo Clinic in Rochester, Minnesota. I really like teaching mostly residents, also work with some medical students, and part of that I was what's called the program director for many years of our neurology residency. So that's kind of where you're like their older brother and helping them you choose who's in your residency and along with a committee, and then you help them. Dr. Michael Stanley was a Bean Award winner as a medical student, and now he's finishing up his training, and he'll become he's a full member, and he's on the board. So, like, to me, that's an example of what we would like to do if it feels like a society people want to be a member of. And otherwise, it just gives medical students exposure to history of medicine and the humanities. What I like about this meeting is because it's not, it's history of medicine and humanities, I always learn many things. Because, some of the history, I know some history of parts of medicine really well, but others, I'm just like everybody else. It's a new subject for me, or I've never even heard of this person before, or what that person did, or sort of more from a social historian standpoint, you found this archive and you asked a question, and then you tried to answer the question as best you could. There's so many of those talks. So I think it's a really nice mix. And people, you should do research, I think, in history of medicine and what interests you. Because that's what's going to drive your curiosity, and to keep asking the next question of why. I think that's, sometimes people wonder, why do you do history of medicine research? And there's lots of reason to do it. Understanding of history of medicine makes you just a little bit more skeptical about the current sort of way we think about, let's say treatment of, I'm a headache specialist, so subspecialist, so migraine.
Right.
Treatment of migraine.
Right.
Well, many years ago, it sort of thought people were, pardon the expression, like psychiatrically unwell. Right. And that is not the case, and people don't think that now. But it wasn't like the people back then were mean. Well, maybe they were, but that was well kind of accepted by many specialists. Right. And now, I'm sure people with migraine are sometimes depressed and anxious. So are people without migraine. They can get depressed and anxious, and there's some comorbidity. They've studied this from an epidemiology standpoint. So for me, it always makes me think, what beliefs do I hold strongly now as when looking at patients with a certain disease that in 15 years or 20 years will be like, what were those people thinking? That's one thing I think is helpful if you understand history of medicine. I think I talked a little bit about the term progress. It also makes me just think, well, yeah, there has been some progress, but it's not this nice straight avenue line of we didn't know anything and there were humors, and then all of a sudden you can get a stent in your coronary artery. There was lots of, people went down the blind alley and had to turn around and come back and say, well, that didn't work. Yeah, sure. And I think you have to be careful. Like sometimes we think, oh, isn't it funny that they thought there were these four humors and there was an imbalance? Well, that was their pathophysiologic understanding. So that's what they based their treatment on. Right. So bleeding and all that, I mean, it sounds kind of, weird now, but if that was what your understanding of what caused disease was, actually it was very reasonable. In the same way that my understanding of migraine now, based on pathophysiology, is why I prescribe certain medicines and don't prescribe other ones. Right. I think probably the final part I brought up was history teaches humility, and I touched on that a little bit. I just think, for me, looking back, and both of the people that I talked about in my presidential address, William Gowers and William Osler, wrote about the mistakes they made and how they learned from their mistakes. And, that shows that you're humble, because they didn't say, Osler was never wrong, and you occasionally see things written along those lines, not necessarily about those two, but about other physicians. They were just always right. Well, sure they were. They were right a lot. But sometimes they were wrong, and they wrote about it to try to teach people. So to me, that's one of the examples. The one I usually use is there have been two Nobel Prize winners at Mayo Clinic, Kendall and Hench. Kendall was a biochemist who discovered cortisone. Hench was a rheumatologist who employed it in patients with rheumatoid arthritis, and they won in 1950, Mayo's only Nobel Prize. And one time I was walking, because I was supposed to give a lecture in Kendall Hench Hall, and I noticed on the sign at Mayo Clinic that they had misspelled Hench's name. And this is it was probably 50 years after they won the Nobel Prize. But I'm like, well, these guys won the Nobel Prize. You know what I mean? And we can't get their name right. What we do, I think, is important. But remember, it's important because you're taking care of people. you're trying to make people feel better or cure them if you can. And most of who's going to remember you are your friends and your family and your patients and your students. And sure, there are some people who are going to make big advancements and will be talked about forever, right, or for a long time. Yep. Most of us are just working and trying, to take care of folks. So.
And I guess in terms of the society and the future of the society, what's your hope for the future of the American Osler Society?
I hope it continues and evolves and becomes more useful to the members. I want it to be something that the members and folks who come to the meeting take away useful information to improve the lives of their patients. And that's really what I hope it is. I mean, I want this to go on and on. You never know. I've been part of societies that were smaller that, I'm not that old, but that have died in my lifetime. I don't think that's going to happen to us, but I think the risk is we need to continue to think about changes to make it relevant. Because time marches forward. History of medicine, humanities research changes over time to some degree. Right. And I think we need to continue to have people in the society who push us. When you take those tests about what your strengths and weaknesses, I'm not the most innovative person. But the nice thing about having a decent-sized society is there are others who are. Yeah. And who, I think part of it is, it's one thing maybe to not feel you're most innovative person, but you need to be surrounded by people of diverse backgrounds. And some of those people are going to be more innovative and come up with really good ideas. And I think that, to me, is, I think maybe the old model, and the old model was great. I'm not knocking it. I think having people who are dedicated to history of medicine and William Osler are very helpful. And They're really the backbone, I think, started this society. Yeah. But moving forward, to kind of continue to push history of medicine and humanities research, I think we need to continue to evolve. So I hope we continue to have members of all ages, sexes, races. I think we need to become more diverse. But in my mind, I'm 53. I mean, I don't know, I'll probably retire at 65. I hope to anyway. I hope we have a better distribution of all those different races, different sexes, and we do have that to some degree now, but we need to do better. And I hope it continues to be a place where I come and I walk away with 10 new things that I'll tell the residents next week.
For you, what's the best part about being part of the American Osler Society?
Oh, it's the people. Because some of these folks I only see once a year at the annual meeting. And to me, that's the best, the camaraderie and the friends. It's such a different society in the sense that, in my neurology meetings, I sometimes meet the same folks, or I know a lot of them and I'll interact with them. But some folks I don't interact with that much until we get closer to the meeting. So it's definitely the people. And I would say the talks. But mostly it's the side talks, and then asking a question about something I've been thinking about where the speaker mentioned a part of it. Or, I guess I've been doing it long enough where sometimes people will say, I tried to find this information, but I just kind of hit a wall. Well, a lot of us are, we know how to do history of medicine. Someone was saying, I don't know how to find this fact from the University of Vienna, and I asked a couple of the surgeons there. Mm-hmm. And I happened to have asked a very similar question. I knew the archivist. They have the data. The surgeons know a lot about the history of surgery, but they're not necessarily know what's in the archive. Right. Even at your own, like at Mayo Clinic, I do because that's kind of part of my work. But many people are like, I don't know if we have this, where in the archive. So that's, to me, the value of presenting your work, listening, trying to help each other out, and just learn something that you take back home. Thank you for your attention, and thank you so much for letting me serve as your president for the last year.